Hi, everyone. I'm Dr. Carolyn Chan, and I am an internal medicine and addiction medicine physician. And I really use motivational interviewing, also called MI, pretty much every day in my clinical practice. And honestly, it is one of the most valuable tools I rely on when working with patients in moments of change. So today, I'm really excited to walk you through what MI is all about, especially the spirit of MI, the mindset and the approach that make these conversations so effective. So by the end of this video, you will have a set of practical skills you can start using right away in your own work. And I'd like to hand it off to my colleague, Dr. Ross Lawson.
Hi, I'm Ross Lawson. I'm an emergency medicine physician and an addiction medicine fellow. I'm a strong advocate for motivational interviewing, and I found it to be an incredibly useful tool when working to help my patients meet their own goals.
If you've ever tried to convince a patient to change a behavior and you just felt like you were pushing a boulder uphill, you are absolutely not alone. Because as clinicians, we tend to rely on explaining, persuading, or warning patients only to see no change at all. Sometimes what we do can even backfire. So, this video is really about a tool that can change that dynamic. So, let's talk about what MI is. MI is a collaborative, patient centered style of communication. MI is specifically designed to support behavior change. And in chronic pain, behavior change can just be incredibly challenging, whether it's trying a new therapy, adjusting medications, or incorporating healthy habits. MI can really help us approach these conversations in a more collaborative manner. It's really important, of course, to acknowledge that ambivalence is normal. When someone is asked to make a change, especially with something that feels unfamiliar, it makes sense that they may feel two ways at once. So, on one hand, they might want the benefits of change, but on the other, they're also really worried about worsening their pain. And instead of ignoring that ambivalence, MI helps us explore it. So, the goal in MI is really to evoke the patient's own motivations to make change. And rather than giving patients our own reasons, we really help them talk through their reasons, why this may matter to them, what type of benefits they hope for, and what type of plan feels realistic and safe. MI helps us partner with patients, allows us to validate their experiences, honor their autonomy, and help them move toward changes that align with their values and goals. The most important aspect of MI is the spirit behind the conversation. MI is grounded in four key elements captured in the acronym PACE. PACE stands for partnership, acceptance, compassion, and empowerment. Partnership really means working with the patient as an equal collaborator rather than an authority. Patients truly are experts in their own lives. Acceptance involves acknowledging the patient's worth, their autonomy, strengths, and perspectives without judgment. Compassion means truly wanting the patient to be better. And when we think about empowerment in MI, this really reflects the belief that patients already have their own motivation and capacity within them. Our goal is not to insert motivation, but to draw it out and help them connect their values to their choices. Let's talk a little bit about the paradoxical effect of coercion and how MI can counterbalance this. So, the paradoxical effect of coercion is the idea that the more we pressure or try to force someone to change, the more naturally they are to defend the opposite or their current behavior. This is a really normal human response. One way to frame this is think of it like a seesaw. Every conversation has two sides to an argument. When the clinician hops onto one side, telling somebody what they should do, the patient almost automatically hops onto the other side to balance things out. We take one side, they take the other. Well, why does this matter? People tend to act on and remember the things they say out loud. So if our approach pushes them into arguing against change, we're actually strengthening their own reasons not to change. So we're going to give you a couple of examples. Mr. M, you really need to start making your physical therapy appointments. You're never going to get better if you keep skipping them.
PT just hurts my back so badly. I've told you that so many times. You know I'm not going to go back.
In this example, we see as the clinician pushes harder, the patient also pushes back in the opposing direction. Here's another example. CBT, Mr. M, it's the right treatment for you. You really need to sign up, and there's absolutely no reason not to.
Just talking about my pain won't fix anything. It's pointless. I don't see any benefit.
And here again, we see the same paradox. The more we push, the more we help people rehearse their counterarguments. MI really helps us step off the seesaw so the patient can take up the side of change for themselves. So, next, let's talk about a couple of common pitfalls of MI. So, the first one is arguing or imposing your own agenda. For example, possibly you walk into a room and you really wanted to talk about physical therapy with a patient, and you are so focused on trying to convince a patient to go to physical therapy, We never learned the perspective that a patient was finally interested in CBT for pain, but we didn't get to hear that because we were so focused on imposing our own agenda. Next, something that clinicians commonly do is take the expert stance instead of partnership. So, this could look like a clinician slipping into a lecture or prescribing, and this breaks the partnership by signaling, hey, I know what's best. And this really can push the patient into the opposite stance. Next, trying to convince instead of evoke. Again, when we argue for change, you need to, you have to, you should. We really are stepping onto one side of the seesaw, evoking the paradoxical effect of coercion. This could look like the clinician stating that the patient needs to stop all opioids due to opioid induced hyperalgesia, resulting in the patient pushing back, saying that they're not interested in doing that. Next, ignoring the patient's autonomy. Statements like you have to do PT, there's no other option, can add pressure and not support self determination. And finally, moving too quickly to problem solving. Sometimes, as clinicians, we're so tempted to say, here's exactly what you need to do to get better. And when we do this, we rush past the patient's perspective and readiness, which can really actually shut down the conversation rather than invite change. So, now that we've given you the basics, what we would like to give you guys is an example of MI consistent behavior. So, this is a case of a patient with chronic back pain who has been taking oxycodone for several years. He firmly believes that opioids are the only thing that has ever helped him, yet he's also reporting that the medication seems less effective than it used to be. You want to explore whether or not CBT for pain might be a helpful tool for managing his pain.
The oxycodone isn't helping me as much as it used to. I think we need to go up on the dose, or maybe make it so I can take it more often.
Yeah, I hear you worked really hard to manage this pain any way you can, and for a long time, oxycodone has felt like it was the only thing that gave you enough relief to get through the day.
Yeah, nothing else really works. The pills are the only thing that have ever helped.
And lately, it sounds like they haven't been giving you the same relief they used to.
No, not really. I feel like they wear off faster or they don't hit as strong, but I definitely still need them. Maybe more of them.
Yeah. So I'm hearing that the medication helped a lot in the past and now it's helping less, but it's still something you depend on to cope with the pain.
Yeah, that's right.
And I recall you've mentioned before that what you want the most is to be able to get through the day with less pain and more control. You don't really seem like somebody who wants to constantly watch the clock waiting for your next dose of medication.
Yeah, I hate that part.
Would it be okay if I shared something some patients find helpful when they're in a situation like yours, wanting more control and less up and down pain?
Yeah, sure, I guess so.
Thanks. So, one approach that some people try is something called CBT or cognitive behavioral therapy for pain.
I don't think therapy is going to help me. I know that medication works for me.
Yeah, I hear that. And I'm curious if something could help you feel steadier and less dependent on waiting for pills to kick in. What type of difference made that make for you?
I just don't want to feel like I'm being sent to therapy because people think my pain is in my head.
That makes total sense. You don't want anyone dismissing your pain. And honestly, I don't either. A lot of people worry about the same thing when we talk about CBT. It's not about saying that your pain isn't real. It really focuses on giving you more tools so the pain has less control over your day to day life.
Well, I would love to not feel so tied to the medication all the time.
Yeah. What I'm hearing is that you want relief that actually lasts, not just short windows where things feel a little bit better between pills.
Yeah, exactly.
I think CBT is something that could help you get more steady relief without much downside. Is that something you'd be interested in getting a referral for?
Sure. I guess just learning about it wouldn't hurt anything.
Yeah, that's all I'm asking for today. Just exploring this possibility. And in the long term, really, our big picture goal is to stick with what works for you and to avoid focusing on what doesn't work for you. In that example, you saw many opportunities for the use of MI, consistent behavior, during a patient conversation related to their pain management. So, in conclusion, MI is a collaborative, person centered way of guiding conversations about change. MI really works by collaboration, not by convenience or convincing. At the core is the spirit of MI captured in the acronym PACE: partnership, working with the person; acceptance, meeting them where they're at; compassion, wanting what's best for them; and empowerment, drawing up their own motivations. We also chatted about the paradoxical effect of coercion, the idea that when we push someone towards change, they naturally push back to maintain autonomy. It's the seesaw, where we take one side of the argument, we unintentionally invite them to argue the other side. So, MI really helps us get off the seesaw and create space for patients to talk themselves into change because their own motivations are the ones that truly stick. And if you enjoyed this video, please check out the other videos in the series.